Hi, and welcome to this installment of Bergeron Briefs. For those of you who haven't seen the show before, my name is Art Bergeron. I'm an attorney. I do elder law. I work at a firm called Myrick O'Connell. There are 60 of us. Everybody does something different. I do nothing but this. I started doing these shows several years ago to supplement the seminars that I do at the Salt Marsh, talking about law issues that seniors tend to have a concern about. The purpose of this show is to have you learn about the people that you should know about if you're a senior here on the island. And one of those is Charlene Thurston. And thank you very much for coming on.
You're welcome.
So as I was mentioning to you before when we talked, Charlene, this show is just about kind of who's here and how they got here and what the programs are and how people could be affected by them. So you told me you didn't grow up here? But you've been here for a long time.
A very long time.
For a long time.
Yes, since 1973.
Since 1973. That's right. And we were joking about that. I was like, yes, I was in college, right? But, it was a while ago. And so why did you come here? And what have you done here? And what are you doing now? And how does that affect seniors who are here and other people who are here?
Well, I came here because I met my future husband here, and we had met before that. So having been from Boston, I thought I'd better come and see what it was like to live on an island.
To live on an
before
island.
Going too far into that
special,
relationship, which is definitely very special.
Which obviously you bought into.
Yes,
right?
It's been a great place to live. It's been a fabulous place to live, great quality of life, and I've really enjoyed it.
And you told me you're one of those people who actually never left. You came here and you haven't been like a block of time in Cincinnati or something.
Right.
You've been
I leave frequently enough to go on visits, but I haven't left the island for periods of time. Right. We've just stayed on the island since then.
And what have you done here, and how did it lead up to what you're doing now?
Well, so I was a nurse at Mass General Hospital when my husband and I met, and when I came here, I started to work at the hospital. And there's actually a very funny story to that. I had been head nurse at a general surgical floor at Mass General Hospital, and I was only 24. So, at that age, you think that you really know a lot of stuff.
Sure, you're really big then, right?
So I thought, I was coming from Mass General Hospital to, little Nantucket Hospital, and I would have so much to offer. But when I asked the then director of nursing, Goldie Rogerson, whether I could come and work here, it was sort of in May, I guess it probably was, of 1973, and she said, "Oh no, dear, we have enough staff." And then I said, but I've been doing all this great work. Wouldn't that be helpful? And she said, No, dear, everything is fine.
Everything's
and she said, well,
fine.
Why? What's making you want to come to the hospital anyway? And I said, well, my boyfriend lives here. And she said, oh, really? Who's your boyfriend? And I said, Barry Thurston. She said, oh, you're Barry's girlfriend? Sure, come along.
Come on in.
So it wasn't my own credentials that got me in.
Welcome to the island.
It was just going with Barry that got me here.
Yep.
So anyway, I did get the job and then started working at the hospital, which was then a little cottage hospital. It's really grown quite a lot since then. And so have been doing lots of different positions at the hospital since then. For the first, many years, I was head nurse of the hospital. We really grew a lot of the programs and the sort of level of nursing and everything that was being offered at the time, and it's really been great work.
Yeah, but always needing to be a general purpose hospital, because the thing about that island is it's got to be here.
Well,
right?
that was one of the things that was really eye opening and really interesting, was that you think going from Mass General on a very acute kind of acutely ill service floor. That you would see everything, and coming here you would think would be so much easier, but it really wasn't, because coming here you had to know how to do everything from a person who was having a heart attack to a person who was having a baby to, at that time, we even had to go out and cover the ambulance. There were no ambulances. There was a van.
You had to cover the. Were you the ambulance?
The staff of the hospital would
actually jump in the ambulance?
You would have to go from leaving one of your patients to go out with one of the orderlies in a van to go and see, the call would come into the hospital. So it was really eye-opening. Great. So it's really been a fabulous place to work, because there's been, much to learn and much to give, which has been good.
And incidentally, I've heard that there are plans to kind of start to grow it yet again. That there's
the hospital. Well, the hospital is is building a new hospital. So the hospital continues to change.
And that's happening fairly soon.
Yes, they're going to. We're actually, our office is being moved off premises as we speak. So
because you're still at the hospital.
Yeah, so we'll get to the program that I'm doing now, which is Palliative and Supportive Care of Nantucket.
Palliative and Supportive Care
of Nantucket, right. Yeah. We started years ago in 1982, actually, as Hospice Care of Nantucket.
And is that a function of the hospital, or is this a standalone 501c3? What
so it's a little more complicated than usual. We always felt as though it would be best to be based at the hospital, and at that time we had sort of approached the hospital about whether they would want to have a program like this, and a really great partnership developed between people in the community who were interested in bringing hospice to Nantucket at the time. This was back in 1982 now, and the hospital. And the hospital couldn't take on anything that was going to be losing money. And as it turned out, but we always felt as though the program should be a hospital-based program because that was the healthcare hub of the island.
Sure.
That's where physicians and patients and nurses and other practitioners were. So
that's where they all are, right?
On a little island, you want to be able to have access to your patients and the staff that you're going to be interacting with. So we always felt as though that was the best way to do it. So we actually developed an arrangement. One patient that had been being served, whose name was Charles Roth, at the time by an all-volunteer hospice program back in the early days, 1982.
I see. So just so that I understand it, so there was it was a volunteer program. Once again, had you created yourselves as a nonprofit, or was this just a bunch of folks?
At that point, it was sort of it was a real grassroots effort to try to create a service for the island. That this is in the early days when hospices were starting anyway, nationally and internationally. What we did, so this one gentleman who had been really, helped by the program, left the program, it's his house, and to be sold, to be used to create, a hospice program.
I see.
What developed was that a partnership between the hospital and then another 501c3 that we developed. It was called Hospice Care of Nantucket Foundation at the time, and now it's Palliative and Supportive Care of Nantucket Foundation, where the hospital would have the program as one of its departments, but it would be funded through this money and also through future donations to the foundation.
I see. So that physically, and were you always kind of on the campus of the hospital?
Yes.
So you were kind of there,
right,
in kind of their structures and stuff, but really funded
self-funded, and still funded through donations to Palliative and Supportive Care of Nantucket Foundation. So we, by creating this structure, we actually charge nothing for our services. All of our services are free of charge, and all of our staffing is supported through donations to Palliative and Supportive Care of Nantucket Foundation. So it's been a great way to provide a service for the island, and keep it fairly streamlined in terms of its costs.
And so tell me what the service is. It's palliative and supportive care. When I hear the words palliative care, I always think of this contrast between palliative and the other, not what I would call
curative.
Curative,
right.
So it's care designed to get better, as opposed to care designed to make every day as good as it can be.
Right. So palliative care is really a broad term, meaning to relieve suffering, really. So the palliative care programs are always structured around trying to improve a person's quality of life, no matter what the illness. For people with serious illnesses. So improving their quality of life by giving really good pain control and symptom management, so good physical care to keep people comfortable, and also good relief of emotional and spiritual distress. So they're always sort of offered through a team of professionals, different professions, nurses, doctors, social workers, chaplains or spiritual counselors, and they generally have volunteers who are available to help their patients as well.
And so you're really trying to deal with that whole package of the things that are important to you.
Right.
And as you say, you tend to be dealing with people who are really sick.
Have serious illness.
They've got serious illness, right?
And they could be in any phase of serious illness. Let me just back up for a minute because I just want to mention one other thing.
Yeah.
One of the things that's really great about palliative care programs and hospice programs, and we can talk about the difference between the two in a little bit, is that they not only focus on the person with the illness, but their families, because these serious illnesses don't just affect the person who's sick.
Right.
They really are family situations, and so you have a whole constellation of people who are being affected by it.
And I suppose that must be really interesting for you to watch as a nurse who's done this for a long time, because I'm sure you find for all of the curative folks also, it affects the person who's there, but also a whole other cluster of people.
Absolutely.
But medicine has tended to, or we've never thought about dealing with that kind of holistically. But except in this area,
right?
Except once you're not going that way, but you're just trying to kind of living with what you've got.
But one of the things that we like to make sure people are understanding now about palliative care is that palliative care can be delivered for any person with any serious illness, any place along the disease process. Even if a person has a disease that can be cured, they still can use good symptom relief and emotional and spiritual support for them and their families.
Oh, so you've really
it's not an either-or thing, which is more what hospice is. And that's really why we changed our name several years ago from Hospice Care of Nantucket to Palliative and Supportive Care of Nantucket.
I see.
Is because all hospice care is palliative, but it's only available to people with a life expectancy of 6 months or less.
That's the kind of the Medicare definition of
exactly
when you're ready for hospice.
Yes,
hospice
and
care.
so that's only end of life care, and it's only if people have stopped pursuing aggressive curative types of treatments. What we realized, and the reason that we changed our name, several years ago now, is that people who are dealing with some of these illnesses, whether they could be cured or not, need that same kind of attention and support. So good symptom control, pain and symptom management, and good attention, as you're saying, holistically, to how they are coping emotionally, how they are, dealing with things, socially even, and also how their families are coping with it. So all of those things are not just important if you're at end of life. They're important from the time of diagnosis onward, even if you're hoping to be cured. And so we now do have a lot of patients, for instance, a lot of our cancer patients that we work with are working towards being cured from their disease, and many of them are. So for those, we're offering those same kinds of, support. And if you think of it as an additional layer of support for patients and families, that's sort of the best way to think about palliative care. And so it doesn't matter whether the disease is curable or not.
And I suppose that must be something that's kind of changed. I'm thinking of this as a layman, regarding cancer. Because when you said cancer, when we were growing up, cancer just meant done.
Yes.
Right? You're just, there may be a given distance until you're done, but you're done, right? Whereas there's a very different feel to that now.
Right.
So are primarily the folks that you're dealing with and the families folks who are suffering from cancer? Or have you found that the disease mix has changed over time also?
Yes, the disease mix has changed, and in palliative care it will continue to change. So a lot of our patients, we have a whole cancer program, which, by the way, I don't know whether you're around when Swim Across America is here, but Swim Across America has been a great, just a great charitable cause for both us.
America.
Swim
Across America.
Right.
So
and it's a
my
national.
deafness that's
it's okay.
Here.
It's a national fundraising opportunity but that is specific to cancer care. So they were just here in August, and in Nantucket we've had fabulous success with it, thanks to the leadership of Jim Pignato and Jill Rothke, and a lot of volunteer members who work hard to make this go. So they've been able to raise this year over $330,000 for cancer care on the island.
Well, that's a significant
It's really fabulous. It's been a fabulous cause and a
That's
great way to support cancer care, both for what the hospital is doing through its oncology services and and the work that we're doing for cancer patients through our organization.
I see. But for those cancer patients, now
Yes.
you're dealing with, once again, people who are cutting back, people who aren't. Other than cancer patients, is there, when you were describing what you were doing, it was sounding like some of the clients who I deal with who are very concerned about dementia issues in terms of their symptoms at the end.
Right.
But some of whom also have these very serious just physical problems. Parkinson's folks, where typically the dementia kicks in at the end, but there's this long period of illness.
Yes.
in
So one of
addition.
the things that I think you'll see more and more
Yeah.
is that as palliative care expands more and more, there'll be much more of a recognition that these patients who are dealing with these serious chronic diseases really need the kinds of care and support that palliative care programs could provide for them. And the thing to remember is that it's not instead of other care. It's in addition to other care. It's an additional layer of support for those patients and families. So I think one of the things that's been great about palliative care programs is that they don't take over from your primary care physician or your oncologist or whichever physicians you're working with.
Yeah.
They add their services to them so that you develop a broader team because you need more services, and you can give patients a menu of services that they could choose from.
So at this point in the organization, do you also provide the services, I'll call them the medical services, the doctor and skilled nursing services, or are you always in addition to those services which are being brought to you by the patient?
So we sort of do both.
Yeah.
So for instance, I'm a nurse practitioner, so I might be seeing a patient of one of our regular, primary care physicians on the island who might be having a lot of issues with pain control and symptom management. And he or she might say, Charlene, will you go and see this patient or have them come in and see you?
Yeah.
And, and sort of let's come up with a better pain control plan and see how that goes. So then I'll be working, with that physician for that patient, and also they might also have visiting nurses, so we might communicate with visiting nurses, or they might be part of the oncology patient care load that are coming to the hospital, so we'll work with the oncology staff around what's going on, so that we try to make things as seamless as possible. We try to really, I think we all, I'm not saying just we, but they also, meaning other practitioners, work together to see if we can make things as coordinated as possible for the patient and still give them and their families sort of this more complete care.
And I would suppose, I didn't mean to
No,
do
that's
something,
okay.
but I would suppose that that's one of the advantages that you have doing that here is you do have a fairly small community.
Right.
So you have all of the players who are used to each other.
Right.
So if someone comes in and people start automatically thinking about these other players
And that's the
becoming
beauty.
involved.
That's actually one
wonderful
of the
thing.
beautiful things about Nantucket is, and one of the reasons that we wanted to be based at the hospital was because then you have, we have the luxury in Nantucket of having everybody together.
Right.
And there aren't a million, there aren't a lot of miles, and there aren't a million different players. So we all know each other pretty well and know how to communicate and know what we all bring to the table for that patient and family, which is really excellent. And we'll see patients wherever they are, by the way. So we'll see patients in the hospital, so if somebody is ill and really needing our services, and they may be end of life but may need good pain control or may need some really good help for depression that they're having over their illness or the loss of someone that they love, we'll visit patients in the hospital. If they're in the nursing home, we'll see them there. If they're home, we'll see them there.
I see. That's
and also
great.
they come into our office.
That's great. So
it's been great work.
Looking forward, right, my intuition when you're describing this is I think, one of the reasons why Medicare only pays for this kind of care when you're at end of life, it's just a price matter, right? They're just
for
figuring
hospices.
Yes.
Hospices,
So
right.
they're willing to pay for these kinds of extra things, but only if you can be demonstrating that you're kind of. And so I guess my question is, when you look forward, do you anticipate other government programs starting to pay for that, or do you anticipate, as just kind of my gut reaction is that you really need that kind of foundation, that kind of ongoing development of a source of money to make sure that in the future, if you're on the island, this is available to you.
So I think that insurance programs and everything are paying for pieces of things, and as you said, for end of life care, for hospice, there is this hospice Medicare benefit. But in order for people to be eligible for that, then patients have to have a life expectancy of 6 months or less and have stopped aggressive curative treatment. And so Medicare will pay for that. So now there is the Cape Cod Visiting Nurse Association is the VNA that services the island now, and they off island had a Medicare certified hospice program. So they've been able to bring those services to the island too. So Medicare will cover those services.
That package.
So sometimes when we were called Hospice Care of Nantucket, we were always too small by ourselves to make that work, to make that pay for itself, because the Cape has a really huge census over on the Cape. They can just use some of that and make that work.
Oh, sure, because to become Medicare certified, I mean, that's a whole.
It was a big thing.
Paper. Well, what is a paper jungle? Now it's an electronic jungle, right? To make that go.
So that's why we developed the program in the way that we did. But we're really happy that they're here now, being able to offer a Medicare certified hospice program, and we still. Oftentimes we'll be working with the same patients, and we always were used to working with the VNA anyway, and so some of the nurses are even the same ones that we used to work with. So we just work together and try to collaborate and stay focused on what the patients and families' needs are, and just try to do things seamlessly for them.
And that's great for you folks, because to some extent that means in some of your cases there are these extra resources that are available, so that you can be kind of you can be just providing more stuff, right? Right. And therefore covering more people.
We continue to provide everything that we've always provided, in addition to working with people now with these other long-term chronic illnesses and also diseases that they can be cured from, whereas before it had to be more limited.
And so when you look forward, in your ideal world, because obviously you spent a lot of time thinking about this, because you've developed a lot of this stuff, right? I mean, you're one of those kind of well-known names here. I'd always one of those like many, like that I keep hearing the same name.
Those lifers,
So when you think about where this goes, where does it go? How do you envision the program changing over the next 5 years?
Well, it's a little hard to say. I think the whole field of palliative care is fairly new in healthcare years. It's probably been about 20 years that many programs have gotten going. The hospice movement really started in the 60s, late 60s. Palliative care as separate kinds of programs came along much after the fact. They really started in hospitals. But we actually have always been pretty cutting edge here, because although a lot of the big palliative care programs and some of the big hospitals now are starting to look at how do we do outpatient palliative care or home palliative care, we've been doing that for years. It's really been great. We've really always, it's one of the beauties of being small. As long as you keep your eyes on the prize sort of thing, you can stay ahead of the game, whereas it takes bigger organizations much more time to
kind of shift.
It's like the ship, right? Exactly.
Yes.
So I think that more and more we're starting to look at how do we help people with serious cardiac disease and respiratory disease, or Parkinson's disease, and Alzheimer's and renal disease, because it's sort of started out of cancer care, but now it's more and more people need. It's really just good care.
It's just good care.
It's just good care. But you can't get it in a 15-minute office visit. It's like our visits usually last an hour or more. So, I mean, we might be in and out quickly if somebody is really stable and they don't, we're just touching base with them.
Right.
But most of our visits are at least an hour. So
And so it sounds like, at least for the folks that have talked to me a lot, for folks who are 65 or older, right? You may be becoming a part of a lot of their lives, whereas they would have only thought that you were a part of their lives if they had cancer.
Right.
Which
or
is
if they were dying.
Or if they were dying.
It's okay. So it's really great to disconnect that and that those are not limitations now.
Yes.
It could be it's people who have these really serious chronic diseases could really use this.
Right.
And people can be in and out. They don't need to they can come in for consultations or questions that arise, or even assistance with doing, say, advanced care planning, as my disease, who is my healthcare proxy? Who do I want that to be? Which means who do I want to speak for me if I can't speak for myself?
All of that, all of those things.
And in addition, what we're trying to help people understand more is that if they do have a serious chronic disease, I mean, everybody should have a healthcare proxy if they're 18 years or older. Everybody should have a healthcare proxy.
But there's a point at which you really have to have one.
Right, and
really.
The other thing is that now what we're trying to help people to understand is that if they have a serious illness, then they should discuss with their physicians what their wishes are and what their values are as that disease progresses, so that instead of waiting for the crisis and there you are in the emergency room and people are wondering what to do, you've already had the discussion that says, I've had this really bad chronic lung disease for a long time. If I get an exacerbation again, if I get into trouble again, I don't want to be shipped off to Boston. I don't want to be intubated. I don't want a tube on. I don't want to be on a ventilator or anything like that.
And actually, this is a great time to be bringing this up, because I know every year I have a friend named Sandy Cordobi, who's a geriatric care manager over in Martha's Vineyard, and we've been trying every year to bring this conversation up right now, before Thanksgiving. Thanksgiving, the time where you're most likely to see a lot of the relatives, right? It's also the time where the relatives are most likely to show up and say, "Oh boy, mine's really changed," But that's the best time to have this kind of conversation.
The kitchen table conversations.
Just because it may be that you're not going to see him again for a year.
Yes.
And as you get old, a lot can happen in that year. Right. So to just be giving people a real sense, not trying to hide where you are in terms of your life, but to be saying, here's where I think I'm going to be this year, and so if this happens, this is what I want.
Right.
That's a wonderful point. Right. That's a wonderful point.
It's great.
Yeah.
It's we really try to encourage people. In fact, in our last newsletter in the spring, we wrote, I usually try to write a lead article about something that would be educational to our readers, because it goes out in the newspaper.
Yeah.
And it was about having the conversation. So it's about getting people, have you had the conversation? Have you sat around and told people, if this happens, this is what I'd like?
Right.
Because you don't want these tragedies to occur in which people don't know what you want, and so you have family members bickering about what you should be doing for each other.
That's right, and they're arguing. The last thing that you wanted for your kids.
Right.
This has just been really informative for me. I think it's been informative for a lot of people. Can you just give the contact information for your organization if people want to kind of know more?
Sure. So we're called, it's a long name now.
That's okay. Talk slow.
It's Palliative and Supportive Care.
Palliative.
Right.
It took me a long time to get that.
You're good.
Palliative and Supportive
Care of Nantucket. The acronym is PASCON, PASCON.
PASCON.
It's a little easier for people to remember.
Yeah.
We're based at the hospital, although because the hospital has a new building, is putting in a new building, we're going to be moved out to Noshop for a, while.
Noshop.
So anyway, right, you can just...
So except for that,
right.
You're not just going to go to the Bean, just to do all the business right downtown,
So it's just 57 Prospect Street, Nantucket, Mass. 508-825-8325.
Can you quickly give them
our website is www.pascon.org.
Great.
So,
Charlene, thank you so much.
Thank you.
This was, I think, fascinating to me. I think for a lot of people.
Great.
Thanks very much for watching, and I look forward to seeing you on the next installment of Bergeron Briefs. Thank you.